Good morning, everyone, and thank you for being here today. I am Dr. Mayuri, and I'm excited to present to you on a very important topic. Today's presentation is about the Nipah virus, or Nipah. We'll explore what it is, how it affects us, and what we need to know to stay safe. Over the next few minutes, we'll cover key facts, transmission, symptoms, and prevention strategies. So let's get started. Nipah virus disease, or NVD, is an emerging zoonotic infectious disease, which means it can be transmitted from animals to humans. It is caused by the Nipah virus, or Nipah, which belongs to the genus Henipavirus within the family Paramyxoviridae. This family includes several viruses that can cause serious illnesses in humans and animals. The virus was named after one of the Malaysian villages where it was first identified, Sungai Nipah. It predominantly affects pigs and humans, highlighting the importance of understanding how it spreads between animals and people. Since its discovery in 1999, there have been multiple outbreaks, and notably, cases have been reported from 5 different countries, including India. This underscores the global concern and the need for ongoing surveillance and research to prevent and control its spread. In India, the initial Nipah outbreaks in humans were reported from West Bengal, first in 2001, and then again in 2007. More recently, since 2018, we've seen cases emerge from Kerala, indicating that the virus continues to pose a threat in certain regions. Currently, there is an outbreak ongoing in the Kozhikode district of Kerala. So far, 6 cases have been reported, and all of these have been confirmed cases. Sadly, there have been 2 deaths. One was classified as a suspect case, and the other as a confirmed case. This highlights how serious Nipah infections can be and underscores the importance of understanding its epidemiology in India, especially in areas where outbreaks have historically occurred. On this slide, we're looking at the ways Nipah virus can be transmitted directly and through various pathways. First, let's consider direct transmission from bats to humans. This can happen when people are exposed to bodily fluids like blood, saliva, or even excrement from bats. A particularly common scenario is through contaminated food, especially in regions where people harvest date palm sap overnight. In Bangladesh, for example, this contaminated sap has been identified as a key source of direct Nipah virus infection. Next, we see human-to-human transmission. This typically occurs through contact with infected tissues or body fluids. We've seen reports from countries like India, Bangladesh, and the Philippines, where such transmissions have been documented, often in healthcare settings or close contacts. Finally, there's transmission via intermediate hosts. This involves animals such as pigs, which might eat contaminated fruits or graze on grass contaminated with bat droppings. These animals can then become carriers, passing the virus to humans who consume or come into contact with them. So, understanding these different transmission routes is crucial for controlling and preventing outbreaks. It highlights the importance of managing contact with bats and intermediate hosts, as well as safe food handling practices. Nipah infection is generally believed to be transmitted through the oral or nasal routes in humans, typically after exposure to infected food, body fluids, or tissues. Once infected, the virus doesn't just stay localized. It tends to spread via the bloodstream, leading to secondary sites of infection. These sites often show lesions that can be distributed throughout the vasculature, including the lungs and the brain. This pattern indicates that Nipah spreads hematogenously, meaning through the blood, which then triggers inflammation of the blood vessels. We often observe vasculitis, or inflammation of the blood vessels, particularly affecting small arteries, arterioles, and capillaries. This vasculitis can impact various organs, such as the brain, lungs, heart, and kidneys, which helps explain the wide-ranging clinical symptoms seen in severe cases. Understanding this pathogenesis is crucial because it highlights how the virus disseminates and causes tissue damage, linking directly to the immune response and the overall disease process. Let's talk about the incubation period first. It can vary quite a bit, ranging from about 6 to 21 days for an acute presentation. However, the key point here is that for the majority of cases, specifically around 90%, the incubation period is less than 2 weeks. This means that most people will start showing symptoms within that 2-week window after exposure. Now, moving on to the case fatality rate. It's quite high, ranging from 40 to 75% in laboratory-confirmed cases. That's a significant mortality rate, which underscores the severity of this disease. Understanding these timelines and the severity helps us appreciate the importance of early detection and intervention, especially given how quickly the disease can develop and how deadly it can be once confirmed. It ties into the overall theme of the importance of vigilance and prompt response in managing this disease. On this slide, we're looking at the clinical presentation in humans, focusing on what patients typically experience during infection. Most patients initially present with common symptoms like fever, headache, vomiting, and muscle aches or myalgia. These are often the first signs that alert us to an underlying illness. As the disease progresses, the symptoms can become more severe and involve the nervous system. Patients may develop acute encephalitis, which can manifest as drowsiness, dizziness, and changes in mental status or altered sensorium. You might also notice areflexia, which is the absence of reflexes, along with signs like hypertension and a rapid heart rate or tachycardia. It's important to recognize that a significant proportion of patients, about 20 to 30%, who recover from the initial illness may still experience long-term neurological issues. These sequelae can include depression, difficulties with cognition, weakness in all 4 limbs known as quadriparesies or nerve palsies. Understanding these clinical features helps us grasp the seriousness of the disease and underscores the importance of early detection and management. It also reminds us that, even after recovery, some patients may face ongoing challenges that require attention and care. When collecting samples for NIV, it's important to focus only on the essential ones needed for clinical management and containment. These include swabs from the nasal and oropharyngeal areas, blood or serum, urine samples, cerebrospinal fluid, and tissue samples such as brain, kidney, or spleen. Since NIV is highly contagious and there's no specific treatment available, minimizing exposure and ensuring safety during collection is critical. Containment of these samples must be strictly maintained to prevent any risk of transmission. If any biochemical or pathological tests are necessary, they should be conducted in fully enclosed automated systems. This approach helps maintain proper containment levels and ensures safe disposal of biowaste, reducing the risk to laboratory personnel and the environment. Overall, these guidelines emphasize the importance of safety, containment, and minimizing sample collection to only what's necessary for effective management and control of the infection. Today, I'll be discussing laboratory diagnosis protocols for Nipah virus. In the acute phase of infection, the most reliable method to confirm NIV is by detecting its specific RNA in clinical samples. This is typically done using molecular techniques like RT-PCR, which are highly sensitive and specific for identifying active infections. As the illness progresses, usually around 10 to 14 days after symptoms begin, the virus becomes harder to detect directly. At this stage, serological methods such as ELISA become valuable. These tests detect antibodies produced by the immune system in response to the infection, helping us identify cases even when the virus itself isn't easily detectable. Connecting this to the overall theme, understanding these different diagnostic windows is crucial for timely detection and response. Early molecular testing helps catch infections in their initial stages, while serological testing is useful for confirming past exposure or later stage diagnosis. This layered approach ensures we have the tools to accurately diagnose NIV across different phases of the illness. Currently, there are no approved treatments or vaccines available for Nipah virus infections in either humans or animals. This means that our options are quite limited. Treatment mainly focuses on supportive care, which includes rest, ensuring proper hydration, and managing symptoms as they come up. There's some research into antiviral drugs like ribavirin, which might help reduce mortality in cases of encephalitis caused by Nipah virus. But honestly, its effectiveness isn't clearly established yet. So, we can't rely solely on that. On the brighter side, immunotherapeutic approaches, such as monoclonal antibody therapies, are currently under development and being evaluated. One promising candidate is M1024, which has already completed phase 1 clinical trials and has been used compassionately in some cases. While that's encouraging, we're still waiting for more comprehensive clinical data. Overall, the key takeaway is that prevention remains our most effective strategy at this point. Since treatment options are limited, focusing on preventing infection through good practices and biosecurity is absolutely essential. Today, I want to highlight some critical points about Nipah virus and its potential as a biological threat. Nipah virus, as many of you know, is a zoonotic spillover, meaning it usually jumps from animals to humans, and these events are typically rare and isolated. However, the concern increases significantly when person-to-person transmission becomes more frequent. In such cases, the virus has a chance to adapt through mutations, potentially becoming more transmissible among humans. This raises the frightening possibility that it could be used as a deadly weapon. In fact, Nipah can infect humans with a case fatality rate that can be as high as 75%, which is alarmingly high. Right now, there's no effective treatment or vaccine available for Nipah virus, making it even more dangerous. The CDC classifies it as a Category C bioterrorism agent. Category C agents are emerging pathogens that could be engineered for mass dissemination in the future because they are relatively easy to produce and spread. They also pose a significant threat because of their potential for high morbidity and mortality, which could lead to major health impacts globally. So, understanding Nipah's potential as a biological weapon emphasizes the importance of vigilance, research, and preparedness in our overall health security efforts.